All right, welcome to the Explainer. Today, we're diving into something you see, I'm gonna bet, almost every single day at the counter: the red eye. Think of this as your go-to guide for confidently handling conjunctivitis, from assessment all the way to counseling. Let's jump right in. Okay, picture this. A patient walks up to your counter, their eye is red, they're clearly uncomfortable, and they're looking right at you for some help. So, what's your next move? This is exactly where we're starting. We're going to break down how to handle those critical first moments. Now, before you even think about reaching for a product off the shelf, the very first step is to get your head straight about what you're trying to accomplish. What are your goals here? Knowing this from the get-go is going to guide every single question you ask and every recommendation you make. Okay, so what are those goals? Well, number one, of course, you want to relieve their symptoms, make them feel better. But, and this is just as important, you're the gatekeeper. That means your job is to prevent complications, to help cure or at least control any infection, and, this one's huge, to stop it from spreading to everyone else. So, with those goals in mind, we get to the real meat of your role: assessment. This is where you get to play detective. You're looking for clues, using the key signs and symptoms to figure out what's really going on. Is it viral, bacterial, allergic? And most importantly, is this something you can handle, or does it need an immediate referral? Think of this table as your ultimate cheat sheet. Seriously. Now, you'll notice redness is pretty much a given across all three. But the real smoking gun? It's the itching. If a patient comes in and their main complaint is severe, can't stop rubbing it itching, your brain should immediately scream allergic. It is by far the most powerful clue you've got. You know, just as important as knowing what to recommend is knowing when to say stop. You need to see a doctor. These right here are your absolute non-negotiable red flags. We're talking severe pain, not just a little irritation, but real pain. Any changes in their vision? That's an immediate stop sign. A whole lot of that thick yellow-green discharge, another huge warning. And hey, if what you're recommending isn't working after a couple of days, it's time to refer. Sometimes making that referral is the best thing you can do for them. Okay, so now that we know when to send people on their way to the doctor, let's focus on what you can manage right there in the pharmacy. We'll start with the infectious types: bacterial and viral. They're both contagious, for sure, but how we handle them, totally different worlds. Now, even within bacterial conjunctivitis, there's a really important distinction you have to make: acute versus hyperacute. Acute is the one you'll see all the time. You know, that sticky, gunky eye that often just gets better on its own. But hyperacute, that's a different beast entirely. It's caused by Neisseria gonorrhea, and it is a true, sight-threatening medical emergency. Remember that yellow-green discharge we just flagged? This is it. If you see that, it's an immediate, no questions asked referral. And here's a surprising stat for those common acute bacterial cases. About 60% of them will clear up on their own. No antibiotics needed. That's a really powerful piece of info, right? It totally backs up a watchful waiting approach in milder cases and helps us all do our part in the fight against antibiotic resistance. And speaking of antibiotic stewardship, here's a huge clinical pearl for you. When it comes to antibiotic eye drops, you've got options, but the fluoroquinolones, we need to protect those. Think of them as your heavy hitters. You save them for the really serious stuff, like bacterial keratitis, not for your run-of-the-mill, uncomplicated pink eye. All right, let's talk about the number one offender, the one you'll probably see the most: viral conjunctivitis. This is the classic pink eye that just spreads like wildfire through schools, daycares, you name it. It's almost always caused by adenovirus, and the telltale signs are a super red eye and a really watery discharge, not that thick, sticky stuff. So since it's viral, antibiotics are completely useless. Your role here is 100% about counseling. It's all supportive care. Recommend some cold compresses, some artificial tears to make them more comfortable. But honestly, your most important job is to become the hygiene police. You have to stress just how contagious this is. It can spread for up to 2 weeks. So constant hand washing, not sharing towels, this is the advice that actually stops an outbreak in its tracks. Okay, let's switch gears. We're moving away from the infectious stuff and into the world of inflammation. We're talking about allergic conjunctivitis. which, as you know, is a seasonal nightmare for so many of our patients. And this brings us right back to that single most important clue. If you remember nothing else from this, remember this. The hallmark, the dead giveaway for allergic conjunctivitis is that intense, relentless itching. The eye is red, sure, it's watery, okay, but it's the itch that tells the story. So how do you manage it? You use a logical stepped care approach. It's simple. Step 1, start with the basics. Allergen avoidance. Advise them to keep windows closed, maybe wear wraparound sunglasses outside. Step 2, non-drug relief. Things like cold compresses. If that's not cutting it, then we move to step 3, guiding them through the OTC eye drop options. And finally, you have a clear timeline for when to bail out. If things aren't better in 72 hours, it's time for a referral. When we get to the actual products, you've got a few classes to work with. Ocular lubricants are great for just physically washing allergens out. Then you have your decongestants. They're great for getting the red out, but you have to warn patients, use them short-term only, or they can get that nasty rebound redness. But the real workhorses here are the ones that target the allergy itself, especially those dual-action drops like ketotifen or olopatadine. They give you fast relief and long-term control. Best of both worlds. Now here is a fantastic counseling pearl that will make your patients love you. For the pure mast cell stabilizers, you have to manage expectations. They are not for immediate relief, they're for prevention. The key is to tell patients to start using them before their allergy season even begins. It's a proactive move that can make a world of difference for their symptoms later on. All right, let's start to wrap this up. We've talked about the different types, but no matter what the cause of that red eye is, there are a few golden rules, a few universal pieces of advice that you should give to pretty much every single patient. Think of this as your final counseling checklist. Number 1, hand hygiene. You can't say it enough. Number 2, no sharing towels or pillowcases. Simple but crucial. Number 3, recommend a contact lens holiday. Just tell them to pop in their glasses and give their eyes a break until they're totally clear. And last but not least, the big clean out. Tell them to toss any eye makeup they've been using and any open eye drop bottles. This is a step people always forget, and it's key to preventing reinfection. And finally, let's talk follow-up. Setting expectations is so important for building trust. For a bacterial infection you're treating, you should expect to see some improvement within about 48 hours. For allergic, give it around 72 hours on a new treatment. But for viral, you've got to be upfront with them. This is a long haul. It can take 2, 3, even 4 weeks to fully go away, and your job is to help them stay comfortable during that time. So there you have it, a really solid, structured way to approach the red eye. The next time a patient walks up to your counter with that familiar complaint, you've got the framework. You know how to assess, how to differentiate, and how to counsel with total confidence. The only question left is, what's one thing you're going to do differently in your very next red eye consult?